Jeff Bezos, the head of Amazon, has gone on record saying that these healthcare issues that are in the broader segment of the economy are his business opportunity.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today, we're glad to have Dr. Rita Numeroff. Rita is the founder and CEO of Numeroff & Associates based in St. Louis. Rita, you're widely published in business journals, you've authored many books. In addition to all of that, you serve as an adjunct faculty at the Olin School of Business at Washington University in St. Louis. Welcome to our program. Why don't you tell us a little bit more about your company?
I'd be delighted, and thanks so much for having me, Bob. I'm looking forward to our conversation. We founded the firm in the late 1980s. We are a global strategy consulting firm focused on what we call industries in transition. So if you think about industries that are going through massive change as a result of one of four factors, they're either dealing with changes in the regulatory environment or changes in the competitive landscape, could be changes in technology, or even changes in market expectations. Any one of those four factors will create the conditions that we've referred to as transition, which is the focus of our firm. And when that happens, it forces even leading organizations to step back, challenge the fundamental assumptions in their business models, how they go to market, the nature of their products and services, the competencies they have. It is wrenching change. And not surprisingly, most organizations will tend to make changes to the margins of their business because the current business model is still throwing cash. So you wind up with disruptors moving into the environment where the leaders who want to hold on to the status quo have been firmly entrenched and wind up typically losing their footing. This was the area that we started in the late 1980s. My background is healthcare delivery. One of my partners came with a background in financial services, and we also had a lot of experience in the high-tech utility arena. And so when we began the business, we thought that industry in transition, because it requires an understanding of the external environment, change in strategy and market shifts. And it also requires the second component of our business, which is really about organizational infrastructure and defining new ways of doing things, new organizing principles, new models. In the case of healthcare delivery, how you define care across an entire continuum, if you will, and new competencies. And thirdly, the analytics work that we do, that we would have something that would be interesting, challenging, make a difference, and would be sustainable. I had no idea in 1987, 88 how stable and on point in terms of transition it would be. But it has been a wonderful journey for us. Most of our work today has been within the global healthcare sector. So we work with major pharma device diagnostics manufacturers. We work with payers, and we work with healthcare delivery organizations. And I think because we work across the entire spectrum of the industry, we bring what I think is an unusual perspective to the table.
Wow, that is a lot. That is a tremendous lot of things to cover there. I think it was Darwin who said, it's not the strongest, it's not the smartest, but those who deal with change that survive. And you are definitely in a change industry. There's no doubt about that. And of course, healthcare, I can't think of anything that is subject to more critical change and activity right now than any other industry. And well, along with the finance, and you have expertise in both. So at UTD, the University of Texas, Dallas, we have an Alliance for Physician Leadership program that's made exclusively for doctors. And we just wrapped up a 4-day intensive. And one of the things that we discussed was really how to utilize clinical decision support and looking at the analytics to improve service delivery, the healthcare service delivery that you speak of. and really try to assess what type of IT requirements are necessary for managing population health. And the one thing that we've learned is the key message for our doctors is that they're moving from this fee-for-service model to a value-based payment model. So the timing to have you on this podcast is absolutely perfect. And I know, Rita, that your latest book, Bringing Value to Healthcare, along with Michael Abrams, it's targeted a variety of leaders. You mentioned the policy leaders, the healthcare delivery leaders, the pharma, and including the physicians. And what we've learned so far is that the physicians, their role is really moving from a craft-based practice as individuals, organized around their specialty, and they're moving to a team-based practice, organized around the patient needs and the delivery process. And so that's the big change that we see, that the doctors are seeing, but there's a bigger change picture out there, of course, that you see. You have a much broader view of what's going on based off your history and background. So if we can, let's further our discussion with the big picture of this new market-based model, and then go a little bit deeper into the concept of and the definition of population health. We don't want to assume that any of our audience is familiar with these concepts. So if you can start with the foundation of those topics, that would really be helpful.
Sure, I'd be glad to, Bob. So if we start with a market-based model as the foundation, one of the things that's really unique about healthcare across the entire spectrum of the industry is that it has not been a market-based model. And it is different from any other part of the economy. The fact that it comprises somewhere between 17 and 20% of GDP, depending upon how those numbers are calculated, is pretty significant that it's not focused on a market model. And so when I think about a market-based model, they're characterized by three things. One, transparency in cost and quality. Secondly, accountability for outcomes so that payment is connected to outcomes that really matter. But what's most important is these outcomes need to be thought of across the continuum, as opposed to looking at outcomes that might be very narrow and specific just at a site level, just within a hospital or a hospital department. And I'm not suggesting for a minute, Bob, that those outcomes at a micro level are not important. There are an element across the entire spectrum of what we need to be looked at. If we think about it from the perspective of a patient journey comes into the healthcare arena from a horizontal perspective. In healthcare, we tended to look at delivery and operations more in a vertical and very siloed unit-specific orientation. That's not consistent with how you build a market model. And the third characteristic of a market-based model is one that allows information that's provided to consumers. And I use the term consumers specifically for two reasons. One, historically, it's been very patient-centered in language, and patients are clearly patients and not in a position necessarily to make good decisions when they're really sick. Obviously, when they're unconscious, they're not able to at all. But when they're healthy or they're needing to work to maintain their health, they clearly act and need to be treated as consumers. And I think increasingly in the market-based model that's evolving, consumers are going to be more in the forefront, and patients are going to need to be engaged as consumers and need to be part of the care plan, the care model, and they have an enormous impact on the outcomes that many physicians say they're uncomfortable being held to because they don't have control over the specific patient behavior. So if we're looking at the definition of a market-based model, from my perspective, it is one that has more clarity around the producer, the seller, and the buyer. Historically, the buyer hasn't really been part of the equation, and it's not yet clear the role that the end consumer will play as the buyer, since largely healthcare services have been paid for somebody else. That somebody else might be the employer, that somebody else might be an individual plan payer that the consumer purchases, or it could be the government that pays for a large part of the services that are provided in this country. But in any case, the notion of a market-based model means, again, three things: transparency in cost and quality, accountability for care across the continuum with outcomes connected to payment, and thirdly, data that allows consumer choice and real competition. When we tie those three things together, we're able to get to value, and that's part of what will bring us to a market-based model. Before I begin talking about my view of population health, which is one of the things that you asked that we talk about, give me some feedback and ask some questions to make sure that what I mean by market-based model is clear, because I think that's really important.
Yes, I think the consumerism aspect of what you're talking about, from a different perspective, if you're a physician and if you're looking at a market-based environment, your view is going to be saying, how can I handle, instead of 2,000 patients, how can I handle 5,000 patients? How can I be smarter and work in a group as opposed to by myself? How can I start to take advantage of analytics and detailed information? How can I relate to my patients on the topics of transparency and cost and quality? And those outcomes are the most important things. So I try to think of this new model really being driven maybe by payment reform, seeing changes taking place in terms of how, instead of fee for service, how that evolution of payment reform starts to take place, forcing some of the changes from at least the healthcare delivery side of things.
I think the points that you're making, Bob, are spot on. I think those elements have to be part of the equation and are of concern to physicians, regardless of where they are in their professional careers. I think if we put this in context for a minute, it will probably be helpful. If we go back to the mid-1980s, there was a little experiment going on in the state of New Jersey, started by CMS, called DRGs. And at the time, CMS had intended to bend the so-called cost curve. And they thought by instituting prospective payment on the basis of bundles of CPT codes, namely these DRGs, that we would get to better health outcomes at lower total cost. And this was the alternative to what was normative at the time, which was usual and customary rates, where physicians and hospitals would deliver a service and they would submit a bill to an insurer, including to CMS. And as long as the prices that were being charged for these services were reasonable and within the realm of what was being charged by similar providers in that particular geography, the bills would get paid. And with new technologies coming to the table and opportunities for delivering care in new ways, moving from inpatient to outpatient settings, even back then, all of a sudden we were beginning to see much more cost coming into the system, and CMS wanted to, as I said earlier, bend that so-called cost curve back then. And I had predicted at the time, I was on faculty at Washington University, and I was teaching a course in health policy at the time. And I had predicted that DRGs were going to lead us down a path of higher cost, poor quality, and poor coordination. And most people thought that I had flown in from another planet at the time. They couldn't imagine how this would be. And unfortunately, all of the predictions that I had laid out and what you referenced in my last book, Bringing Value to Healthcare, have unfortunately played out in exactly the way that we had predicted them. And the reason, very simply, there was no connection between payment and outcomes. And the first time that CMS has attempted to fix that connectivity was in 2008, where they instituted what have become known as never events, essentially saying we're not going to pay hospitals to fix problems that they should have prevented in the first place.
Right.
And we know in the industry, and I'm sure you've talked about this in some of your academic work, that hospitals, if we look behind the curtain, are known by people who are administrators and clinicians in these institutions are often not safe places for a whole variety of reasons. Are people intentionally going out of their way to make them unsafe? Of course not. But because of lack of time, lack of attention, lack of discipline, people being stressed, some of them experiencing burnout for a whole variety of reasons, the current model is creating conditions and organizations that puts people, caregivers and consumers, patients at risk. And it shouldn't be like that. And my contention is that most of it is driven out of a payment model that has, up until very recently, driven us to do more, regardless of whether we need to do those services, and that those services need to be delivered in high acuity, intensive, more expensive settings, because that's where the money has been. And that's what's generally referred to, as you know, as fee for service.
Right.
And so the notion of we need to move from fee for service to fee for value, I don't think it really gets at the heart of the problem. The problem isn't fee for service by itself. It's that we're paying without connection to outcomes. And we're not paying for preventing things from happening. And if all I'm doing is getting paid when I intervene as a physician, then the challenge is doing more and more and more, which will run me ragged really quickly. And how do I manage these ginormous panels of patients, as opposed to maybe engaging with people in very different ways and using resources in the community in very different ways to get to better outcomes. And so it's not about how much I can do. It's doing what I'm doing differently and really making sure that we're diagnosing what a particular patient or set of patients needs and optimizing where that patient gets treated, how, and by whom over an extended period of time.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
You know, this evolution of moving this payment method from, fee for service, moving more to performance, episode-based payments, moving to population-based payment, capitation, all those things drive a whole new way of doing things. And it really focuses right back on what you said initially regarding the transparency and the cost and the quality. And along that line, being a consumer today of healthcare, when you think of being a consumer for consumer products, you shop for things, you look for value, you do have transparency, you understand the cost and the quality of anything that you're looking for. And in today's marketplace, I notice that there's more and more consumer involvement in terms of high deductible health plans from an insurer's perspective, having people having an interest in shopping for those things, not for their emergency items, but for those items that are part of their everyday health care, where they make decisions and the information that they have is readily available. Recently, I had my annual physical and they asked for me to get an x-ray, and I was on a high deductible health plan. So I was in the hospital and I asked the admission people, this is covered as something which is preventable and not an extra expense. And they said, the x-ray will cost you $683. And I said, if I'm a self-payer, what will it cost? and they said $64. So I gave them the Visa card and said, I'll take the $64 version of it. And it's just startling, absolutely startling to see that transparency is hidden from us, and it won't be going forward, I think. And I think it really brings up an interesting perspective because we're hearing a lot of things in the news today. We hear about tragic things like recently at Vanderbilt where a patient died due to an error. And a lot of people die in hospitals due to errors. But more on the positive side of the news, we're starting to see more things about CVS and Aetna and Walgreens and Humana and Amazon, Chase, Berkshire Hathaway. What's your perspective? Share us your view of what you see happening there in that consumer space and why these things are starting to formulate.
I think it's a great question, Bob. And it goes back to what I was suggesting earlier, that the incumbents who have been leaders in a particular industry who are doing well under the current rules of engagement are typically loath to make changes to their business models. Doesn't mean that the business model shouldn't change. It just means that those that have been leaders are loath to change. And what happens is that we have others that have largely been outside the industry looking at the current dynamics as ripe for disruption. And so the vertical integration examples that are out there, whether we're looking at Walgreens, Humana, with each company buying stakes in each other, or we're looking at CVS, Aetna, and we're looking at the relationship between Amazon, JP Morgan, Berkshire Hathaway. All of these are disruptive moves, and probably the one that has had the strongest signal for traditional players in the healthcare delivery space has been the announcement by Amazon in the beginning of this year about their relationship being formed as a group of very large payers who essentially want to change the landscape in healthcare. The other thing that I think is really important is that immediately after this announcement in the beginning of the year, the stock prices for healthcare public payers quickly went down. I think they've rebounded to some extent. Atul Gawande, who is the head of this venture, has been on a listening tour to understand the employees' concerns in all of these companies, what's keeping them up at night, and beginning to come up with solutions. And one of the things that he's heard from employees is reflective of what we hear with those that are employees and generally in the market outside of these companies. There are issues of accessibility, there are issues of transparency, there are issues of coordination and so forth. And while he's committed to addressing a new model that fits the needs of his employees, Jeff Bezos, the head of Amazon, has gone on record saying that these healthcare issues that are in the broader segment of the economy are his business opportunity. And so he's gone on record saying he wants to disrupt the model, looking at where there are discontinuities. Clearly not being consumer friendly is one of them, introducing safety being another. And over the last 10 years, Amazon has been making systematic investments in technology that will allow them to play in new ways. And so I think that delivery organizations should take a look at this and be concerned. There's also a move from treatment in traditional inpatient settings to more outpatient settings. And we've done some work earlier this year, specifically looking at the move from inpatient to ASCs in the area of orthopedics, which has been historically a big moneymaker for most healthcare delivery organizations. And to the extent that they can no longer count on the heads and beds funding in orthopedics, assuming we have the right patient and the right facilities in a given market for care being delivered in less intrusive settings, less intensive settings, less expensive settings, that's going to be good for the consumer. and outcomes at the end of the day are going to be most important. And I would argue that every clinician, regardless of where they are in their professional journey and the kind of organization that they work in, need to be concerned about the economic and clinical value of the care that's delivered in their particular facility. So I think that these disruptions are going to continue. We are in the midst of a major change in the face of healthcare. It's an exciting opportunity for players within the market. And I think it's also an opportunity where there are a lot of people who have a great deal of angst, who really aren't sure about what the capability set is that's going to allow them to cross the bridge from where they are today to really a fundamentally different approach to this.
I know there's so many changes out there, Rita. The gig economy, the millennials, they don't have insurance. A lot of them are looking to be, independent. You've got this huge age wave of Medicare, thousands of people joining every day into the Medicare marketplace. There's a tremendous amount of opportunity for innovation and for better definition of the whole healthcare space. And we know it's an American sickness. We know there's a lot to be done. It'll certainly be in the political regime of activity in 2020 and going forward. And just the financial aspect of it alone is, as we all understand it, to be a very important part of our overall economy. So kind of wrapping things up here, Rita, what's next in store? What's your next book going to be about? Any news here?
I'm not sure that I'm ready to announce that today.
Okay.
We're obviously working on new innovations in the market and bringing solutions that are really going to make sense in an American way. I think that we can do a much better job. We are looking at social determinants of health and beginning to talk about these in ways that we never did as a nation before. I think that's very exciting. We're spending an incredible amount of money in this country on lots of things that are not coordinated and not getting to the value that we need. And we're degrading opportunities for investing in education and basic infrastructure and a whole variety of other things that will make us a lot more competitive on the global stage. And I think we can do better. We need to do better. And we want to be in the forefront of that.
Well, I got to tell you, this has been an exciting opportunity to learn more about what you're doing. It's a real great honor to have you on our podcast, and we're going to stay tuned and follow you as you continue on the journey here. So really want to appreciate your time today and being part of what we're doing.
Thanks so much, Bob. It's a pleasure talking to you today.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.